Hi class and Dr. Mates. Welcome to my case study. Today we'll be discussing a fluid compartment syndrome case study on a patient with chrest to cryptococcal meningitis. Let's get started. To get started, meningitis can be caused by bacteria, viruses, or fungi. This case involves a patient who acquires meningitis that is caused by a fungus. There are numerous species of fungi that can cause chrest to cryptococcal meningitis. However, the two most pathogenic fungi are C. neoformans and C. gattii. For this case study, I will discuss a patient who is infected by C. neoformans, the fungus species. C. neoformans is nefarious for affecting HIV-positive persons or immunocompromised persons. They are an encapsulated yeast, which helps them initially to evade detection by the human host. Pigeon poop is a common vector. Typically, a person will inhale the C. neoformans after entering a contaminated room with pigeon feces. This organism affects many people, and about 1 million cases worldwide are reported yearly. Finally, this organism lives in temperate regions, so areas that are not tropical, not Arctic, but all the areas in between. So yes, C. neoformans can be acquired in the United States. Before we start on the patient's history, let's start off with his symptoms and discuss what brought him into the clinic in the first place. It is to be noted that the case study did not specify if this was an ER visit or primary care or with a neurologist or other. So, the patient in this case is a 52-year-old male who lives in the United Kingdom. And he is presented to the clinic with non-vertigo dizziness, which indicated the patient has experienced feelings of motion sickness or lightheadedness rather than experiencing the feelings of spinning. Next, the patient mentioned he was experiencing bilateral hearing loss. It was determined that bilateral moderate severe sensory neural hearing loss, SNHL, was occurring. SNHL occurs when the auditory nerve or brain processing centers for hearing are not working as normal. This leads to difficulty hearing in loud spaces, following a conversation if multiple persons are speaking in the vicinity. Hearing high-pitched sounds and voices can also sound muffled. Finally, he reports a history of having headaches and double vision for about the last 2 months. Our 52-year-old patient is immune competent, so the patient has no history of HIV or other immunocompromising conditions. He is of Chinese heritage. He has a history of hypertension and hyperlipidemia. His history includes a pre-existing right-sided sensory neural hearing loss, but the cause is unknown. Apologies. He was also previously admitted for nonspecific symptoms that was diagnosed with left abducens palsy. Abducens palsy is when the left eye unintentionally abducts outward and the right eye remains with normal function. Abducens palsy can be caused by various factors, but includes elevated pressure from cranial swelling that can occur in meningitis. His abducens palsy's cause is unknown. The case study did not include any family history or a current medication list. The case study did not outline the clinicians involved in the care of this patient. However, I will make an educated guess about the patient's healthcare team. I don't think the UK has advanced practice practitioners or APPs, so it is very likely a primary or ER doctor managed him initially when he was diagnosed with left abducens palsies. Then during this visit today, he is likely being evaluated by a neurologist. The neurologist would have a team of nurses and imaging techs to help them run the tests this patient will need. The patient may or may not have a family member or close friend in the room with them. If this patient is traveling from the UK to China, to the UK from China, it just happens to become ill during these travels. An interpreter may also be needed. Physical exam. So the patient is afebrile, so no fever, is non-toxic looking, suggesting he did not appear to be in distress, and he now has bilateral impaired abduction of his eyes. So in the clinic today, both eyes were rotated outward. His history included having only one abducted eye previously. Other neuroexam markers were insignificant. So this patient is obviously experiencing some sort of medical problem. His hearing is worse than normal, his eyes are abducted, and he is experiencing headaches and non-vertigo dizziness. What's next? Blood work was ordered by the supervising physician. Blood work ordered including a white blood cell count, an ESR, SPL, and communicable disease markers for HIV, TB, and syphilis. His white blood cells were mildly elevated. The normal range is 4 to 11 times 10 to the 9th cells per liter. This patient had 10.4 times 10 to the 9th cells per liter, so on the upper range there. And an elevated white blood count can indicate that the body is fighting an infection. His ESR was elevated as well. The normal range is less than 15 micrometers per hour, and this patient was equal to 15 mm per hour. This an elevated ESR indicates inflammation in the body somewhere. His SPL was normal, so he does not have sepsis, and his HIV, TB, and syphilis tests were all negative, confirming he is not immunocompromised nor experiencing symptoms from these diseases. Because his white blood cell and ESR were elevated, and with his symptoms mentioned earlier, a CT and MRI were ordered. A side note, the MRI was likely ordered with, the brain CT that was ordered was probably done with contrast. The contrast will help amplify any detecting infection. However, it was not indicated in the case study. All right, imaging results. So both the MRI and CT scans showed mild hypersensitivity intensity in the bilateral temples and the perioccipital sulci. This means most of the patient's brain was showing inflammation. This highly suggests meningitis. No other abnormalities were noted. Because meningitis is suspected, the next step was to order a spinal lumbar puncture to evaluate the causative agents of the meningitis. All right, lumbar puncture results. Before we get started, it is known that spinal fluid should be sterile in a healthy person. For this patient's results, his protein count is elevated. The typical range is 0.15 to 0.6 grams per liter, and his was an entire 1 gram over 1 liter. His glucose results are low. A typical range for glucose is 2.77 to 4.44 millimoles per liter. And his is only 1.4 millimoles per liter. When glucose levels are low, this can indicate that a pathogen in the spinal fluid is using glucose as food and energy. He has nucleated cells. Typically, spinal fluid in a healthy person will only have 0 to maybe 5 nucleated cells per lumbar sample. This patient had 119 nucleated cells, with more than 50 of those being lymphocytes, which indicates the body is fighting an infection inside his spinal fluid. Laboratory tests were also performed on the spinal fluid to detect the pathogen, and Cryptococcus antigen was positive, suggesting a fungus, and therefore an Indian ink stain was done on the sample, providing the pathogen to be confirmed as C. neoformans. All right, diagnosis. Now we know the patient is suffering from a fungal infection that is infecting and targeting his spinal fluid and his meninges. And the causative agent is C. neoformans. The patient now needs to be informed, and the next step is to formulate a treatment plan. Treatment plan. The patient was given a 6-day course of IB amphotericin B and a 15-day course of flucysteine simultaneously. Both of these are antifungal medications reserved for severe fungal infections, and both are typically given intravenously. Upon completion of the flucysteine, the patient was given a 4-week course of oral fluconazole. Dosing was not specified in the case study. Outcome. So the patient had his first follow-up about 1 month after diagnosis. The patient had a good clinical response to the antifungals and completed all courses of the antifungal medications without issue. At this 1-month follow-up, the auditory tests were performed again. The patient's results were still poor. The SNHL results were severe for his right ear and profound SNHL for his left ear. The clinician thought it best to have the patient follow up and be evaluated for a cochlear implant surgery. This is because even though this is fungal meningitis, patients who survive bacterial meningitis typically sustain hearing loss, and many of those patients undergo cochlear implant surgery. At this patient's second follow-up, about 2 months after diagnosis, he is being evaluated to undergo cochlear implant surgery and is getting a repeat brain MRI. His brain MRI proved that both of his vesticochlear nerves had returned to baseline, so no abnormal enhancement was noted on the MRI. This is much different than his first MRI, where both temporal and occipital regions were enhanced. At 2 months now, his vestibular issues have improved. His non-vertigo dizziness has improved, which he reports to be resolved, and his bilateral impaired abduction of his eyes has also been resolved. So his eyes now rest in a normal neutral state. Regarding his hearing, SNHL has improved slightly and also spontaneously bilaterally for both ears. Because of this, his consideration for a cochlear implant was postponed. All right, outcome. Third follow-up. The follow-up was at 11 months post-diagnosis. The patient reports and physical exam proves that his vestibular issues remain resolved, so still no dizziness and no ocular impairments. The hearing loss has continued to improve spontaneously. This is very notable. In bacterial meningitis, it is very rare that hearing loss improves. The SNL hearing loss reduced from severe to moderate to the right ear. This can be concluded to be back to normal because prior to being diagnosed, he had mild to moderate right-sided hearing loss. The SNHL reduced to baseline for the left ear, meaning no notable hearing loss was noted for the left side. This patient has gotten so much better. A fluid compartment syndrome that is significant to understand and learn about is meningitis. This underlines how meningitis is a very serious condition that can be complicated to diagnose and take a long time to resolve. I learned that fungi can be causative agents in meningitis, not just bacterial or viral. In regards to the patient, from the onset of symptoms, which was about 2 months prior, to the diagnosis to about 11 months post-diagnosis, the patient had more than a year of battling this illness and therefore was sick for more than a year. At 11 months post-diagnosis, now at the third follow-up, I would say the condition is now resolved, especially because his hearing and vision has returned to baseline and his dizziness was resolved. Since he was successfully treated, I would assume the prognosis for him is good, but I'm curious about the long-term effects and the survival rate for crassocryptal meningitis. The spontaneous recovery of this patient's hearing loss is unique to crassocryptal meningitis and typically would not occur in bacterial-caused meningitis. Information I wish was included in the case study. In my opinion, the case study was straightforward, but I also think the case sacrificed information for the sake of being concise, and I felt additional information could have been included that would have been relevant to this case. First, I wish there was more patient history. For example, I would have liked to know if the patient was a UK citizen or traveling. This might have given the reader extra insight of how the organism was contracted. I was also very surprised that the patient history did not include a medication list, as he likely would have been on specific medications for his hypertension and hyperlipidemia. Certain medications can cause side effects, and this might have caused the dizziness and vestibular dysfunction. I would also like to know if the healthcare team managing this patient at his initial visit was an ER team or primary care, or was this a neurology team? I also wish there was more information about who was present during the first visit and who was in the room. I also want to know more information about the lab and imaging results. I wish the normal lab values for the tests were given in the case study because I had to look up all the normal value ranges for all the tests that were done. A final follow-up, such as a 2-year follow-up, would have been nice. I'm curious to see how he fared after a couple years after his crassocryptococcal meningitis diagnosis. I also would have liked the case study to explain why they themselves thought an immunocompetent person would have acquired this disease. Did he have maybe an underlying health disorder that was missed or overlooked or not included? He might need further workup on something else. Strengths. I just explained what I wish was included in the case study, so I'll consider the lack of information as this case study's weakness. For its strength, however, I'm happy to have read about a more rare presentation of meningitis. The topic was interesting and insightful. The case study also did a good job of contrasting the various managements of hearing loss in cryptococcal versus bacterial meningitis, advocating for a more conservative approach for the fungal-caused meningitis. This balanced perspective was supported by the patient's clinical outcome and highlights the importance of individualized patient care. Treatment and dosing. What were the prescribed medications and dosing of the case study compared to the standard of care guidelines for cryptococcal meningitis? In the case study, the treatment plan was amphotericin B times 2 weeks plus flucysteine times 4 weeks and then fluconazole for 4 weeks, all unknown dosing. I researched the medications and dosing that are standard of care to treat cryptococcal meningitis. The treatment plan that was issued to the patient falls almost within the guidelines, with first-line treatment being both the amphotericin B plus flucysteine for 4 weeks. There is some variation here, with the amphotericin being a shorter course in the case study. Then the guidelines suggest fluconazole for 8 weeks, and then ongoing fluconazole at a reduced dose for another 6 to 12 months. The case study did not mention if the patient continued with an additional reduced daily dose of fluconazole. There's another deviation here. Ultimately, the case study for this patient, the patient did improve, which suggests that each patient does need a personalized treatment plan. I also discovered that patients can be treated initially and solely just with amphotericin B, but this typically is avoided because mortality rates are higher. But this scenario happens from time to time because flucysteine is expensive and sometimes not on hand in certain areas or countries. Alright, what happens if there's an allergy to one of those antifungals? So what if a patient was diagnosed with cryptococcal meningitis but had an adverse effect from the antifungals? What happens if there was an allergy to amphotericin B? It is very rare, but it can still happen. What happens in this case? What does an allergy to amphotericin B look like? I found a brief case study outlining a woman who was intravenously administered amphotericin B and soon after went into cardiac arrest and needed CPR to be resuscitated. The incident of this allergy is so rare that there is a case study on this side effect when it does occur, but also the case study suggests that anaphylaxis could occur as well. An alternative treatment plan. So if a patient was allergic to amphotericin B, how could they be treated? A small study that needs to be replicated to prove its efficacy and was conducted by the Department of Infectious Disease in China found that a trial of 38 participants treatment for non-HIV cryptococcal meningitis had relative success treating with just fluconazole and just flucysteine, a couple 100 milligrams per day alone. This is a possible treatment plan, but as I just mentioned, this was a small study and would need to be further evaluated. This suggests the possibility of successful treatment without amphotericin B if there was an allergy. What would occur if a patient that lived in a remote area with limited health care or had limited to no insurance coverage? Treating cryptococcal meningitis in a patient who lives in a remote area with limited healthcare options or no insurance coverage presents significant challenges. There are limited care specialists in rural areas, so this might lead to delayed diagnosis. Cryptococcal meningitis often requires the expertise of infectious disease specialists and neurologists who may not be available in rural settings. Without access to specialized care, the quality of treatment might be delayed. Unfortunately, for a good prognosis, cryptococcal meningitis does require early diagnosis through the lumbar puncture and spinal fluid analysis. In remote areas, access to these diagnosis tools may be limited, ultimately leading to delays in initiation of treatment. Rural patients will also likely have limited access to medications. The standard treatment for cryptococcal meningitis involves antifungal medications such as amphotericin B and flucysteine, followed by long-term fluconazole therapy. These medications might not be readily available in remote healthcare facilities. For low-income patients, the high cost of these medications, especially the flucysteine, might be prohibitive. Transportation barriers are also possible. Regular monitoring and follow-up care are essential for managing this disease, as treatment can last for several weeks or months. Patients in remote areas may struggle with transportation to healthcare facilities, leading to interruptions in treatment and increased risk of complications. Financial strain. Without insurance coverage, the costs associated with diagnosis, treatment, and follow-up care can be overwhelming. Patients may face financial hardship, which could lead to noncompliance and treatment recommendations, further exacerbating the disease. Ultimately, patients who live in rural areas or who are considered low income have an increased risk of mortality. Given these barriers, patients in remote areas with limited healthcare access and or persons with little to no insurance are at higher risk of poor outcomes. All right, and these are my references. The end, everyone. This is the conclusion of my overview for this case study, which discussed meningitis, a fluid compartment syndrome caused by the fungus called C. neoformans. I hope you enjoyed this presentation and learned something new. If there are any questions, please reference the reference page or reach out individually to me on campus. Have a good day, everybody.